I am absolutely delighted to be introducing Dr. Keiko Greenberg, who's an assistant professor of medicine at MedStar, Georgetown. Keiko came to us from Harvard to UVA for medical school to internship, residency, and fellowship at Johns Hopkins, where she obtained a Master's of Health Science degree. She stayed there as an assistant professor, but luckily I was able to steal her away from there, and she joined us in 2020. Keiko's really published several things on various topics. Her field of expertise clinically is on dialysis, where she's published on home hemodialysis, and she runs our home dialysis unit. From an educational standpoint, she's our associate program director. I think the house staff knows her very well. Nationally, she's on the National Kidney Foundation CME committee, and we're so happy that she's going to give us her talk today on updates in nephrology.
I appreciate the opportunity to talk to you all today. As Dr. Choi said, I'm Keiko Greenberg, and I'm assistant professor of medicine. I've been here for almost a year and a half now. I joined since the pandemic, which has been an interesting time to start a new job. But I'm going to talk about some of the exciting things that have been happening in nephrology recently. I think it's a very exciting time. I think there's a lot more. I think any nephrology updates in past years, may have been much shorter, or not as maybe nephrocentric. But as you will see, there are several updates, several things I'm going to talk about that are affect many of our patients, and actually one of the things that affects all of us. And so I'm going to start by talking about the benefits of SGLT2 inhibitors in non-diabetic kidney disease. And then I'm going to briefly just mention that there's a new mineralocorticoid receptor antagonist on the block called finerenone, and then review briefly the new equations to estimate GFR without race. And so we'll start with a couple cases. So the first is a 57-year-old man who sees me in clinic for chronic kidney disease due to secondary FSGS. His other medical history includes hypertension, hyperlipidemia, obstructive sleep apnea. His medications include an angiotensin receptor blocker. His creatinine ranges from 1.4 to 1.6. And urine albumin creatinine ratio is 536 milligrams per gram, despite being on the maximum dose of telmisartan. A second case is a 54-year-old man with CKD due to IgA nephropathy. His medical history includes psoriatic arthritis. His medications include lisinopril, and his creatinine is 1.75, which translates to eGFR around 43. And urine albumin creatinine ratio is 182 milligrams per gram, which is not that bad, given that he's on the lisinopril. The lisinopril is dose limited because he doesn't have hypertension, so he's on the maximum dose that he can tolerate. The third case is a 23-year-old woman with CKD due to Alport syndrome, and she is on lisinopril because she has significant proteinuria. Her creatinine is quite good, but her 24-hour urine protein, the most recent one, showed over 2 grams of proteinuria in 24 hours. And so what do these folks all have in common? They all have chronic kidney disease with proteinuria. None of them have diabetes, and all are on an ACE inhibitor or ARB. Their blood pressure is well controlled. So the question is, what else can they do, or what else can I offer to prevent progression of their kidney disease? And so these are all patients, that I've seen, in the past 6 months that I've recommended adding an SGLT2 inhibitor. And so just to quickly review SGLT2 inhibitors, we'll start by talking about the SGLT2, which is the sodium glucose cotransporter 2. It's located in the apical membrane of the proximal tubule cell. Right, so the filtrate is coming down, and then glucose and sodium are being absorbed, reabsorbed. And so this process, the SGLT2 in the proximal tubule is responsible for reabsorbing at least 90% of filtered glucose. And so, inhibition of SGLT2 inhibitors leads leads to glycosuria and natriuresis, which leads to beneficial effects such as negative caloric balance and weight loss, decrease in hemoglobin A1C, increase in uric acid excretion. I think further, there's another glucose transporter that reabsorbs more glucose in the setting of SGLT2 inhibitor use, which actually leads to increased excretion of uric acid. And the natriuresis is associated with beneficial effects such as decrease in blood pressure and plasma volume. And then we're going to talk a little bit about tubuloglomerular feedback because that's most relevant to the kidney. But all of these together, lead to benefits, demonstrated benefits in cardiovascular and kidney disease. So tubuloglomerular feedback, just briefly, it's one of the mechanisms that the kidney uses to regulate blood flow into the glomerulus. And so normally you have, when you have distal delivery of sodium chloride to the distal tubule, you have, that suggests, adequate circulating volume. And so it regulates, the higher the sodium chloride delivery, the increase in constriction, and so regulating the amount of blood flow into the glomerulus. In diabetics, there's going to be more more glucose being filtered, leading to increased reabsorption of glucose and sodium, leading to reduced distal delivery of sodium, and so effectively mimicking decreased effective circulating volume, and because of the decreased sodium chloride delivery distally, dilatation of the afferent artery and increased blood flow into the glomerulus, leading to renal hyperperfusion and hyperfiltration, which leads to development of diabetic kidney disease and progression of kidney disease. And so by blocking SGLT2, you have less reabsorption of both glucose and sodium in the proximal tubule. You have increased sodium delivery distally to the macula densa, and then you have afferent vasoconstriction, reducing the blood flow into the glomerulus, and reducing intraglomerular pressure and hyperfiltration. So SGLT inhibitors are not new. So the three that I think of, dapagliflozin, canagliflozin, and pagliflozin, have been around for 7 to 8 years when they were first approved for use in type 2 diabetes. And then over the next few years, you had these major studies showing that SGLT2 inhibitors reduce major adverse cardiovascular events in type 2 diabetics. And then in mid-2019, you had the publication of Credence, which was the first time there was renal-specific outcomes. And so in type 2 diabetics, canagliflozin reduced progression of kidney disease. And then later in 2019, DAPA heart failure showed reduction in cardiovascular death and heart failure hospitalization in heart failure patients. And this is the first time up to now. All the studies included type 2 diabetics only. And here, DAPA heart failure is the first time that we have a study that includes non-diabetics. So anyone with heart failure, I think about 40% had diabetes, meaning the rest did not. And so 2020, so about a year ago, DAPA-CKD was published in this study I'm going to talk about. And so the DAPA-CKD trial stands for dapagliflozin in patients with chronic kidney disease. It was published a little over a year ago. Over 4,000 adults were enrolled and randomized 1-to-1 to dapagliflozin or placebo. They all had kidney disease defined as having a GFR between 25 and 75 milliliters per minute per 1.73 meters squares, and a urine albumin to creatinine ratio between 200 to 5,000 milligrams per gram. 67% of the participants had diabetes, meaning a third did not. And virtually all the patients were on an ACE inhibitor or angiotensin receptor blocker at the start of the trial. And so these are the outcomes. So the primary outcome was this composite outcome, looking at decline in estimated GFR, end-stage kidney disease, defined as dialysis, kidney transplant, or estimated GFR less than 15, death from renal causes, death from cardiovascular causes, and there were some other secondary outcomes as well. But if we look at the results, so looking at the primary composite outcome, which again is listed here, we see that there's a almost 40% reduction in this primary composite outcome, which is highly statistically significant. Again, also looking at the renal specific composite outcome, which is the same as the primary outcome with just with cardiovascular death excluded. So it's significant decline in GFR, development of end-stage kidney disease, or death from renal causes. Again, almost a 50% reduction. And so this, I actually show patients these tables and say, do you want to be in this group, or the group where about 9% of the patients end up on dialysis, or have significant decline in kidney function, or this group where over 16-17% of the participants ended up with a bad kidney outcome, and it's pretty convincing. And similarly, there was also a reduction in the risk of death from cardiovascular causes or hospitalization for heart failure, and then all-cause mortality. But what was exciting for me as a nephrologist about this study was looking at this table and seeing that about 2/3 of the patients had diabetes, but then there were almost 1,400 patients who did not. You can see that whether patients had diabetes or not, they benefited. And safety-wise, I'm not going to belabor this point because these drugs have been available for some time, but the overall incidence of adverse events was similar between dapagliflozin and placebo. Hypoglycemia and volume depletion were slightly more common in the dapagliflozin group, which makes sense based on the mechanism. But there was no difference in renal-related adverse effects, which essentially is referring to acute kidney injury. And in patients without diabetes, there were no episodes of diabetic ketoacidosis or severe hypoglycemia. Okay, so based on this data, so this April, the FDA approved dapagliflozin to reduce risk of kidney function decline, kidney failure, cardiovascular death, and hospitalization for heart failure in adults with chronic kidney disease who are at risk of disease progression. And so this is from the news release from the FDA. FDA approves treatment for chronic kidney disease, and the approval is the first to cover many causes of disease. So as we all know, there are numerous causes of chronic kidney disease. So the question is, which patients were included? Is this data applicable to the patients I'm seeing? And so looking at the baseline characteristics according to the cause of chronic kidney disease, again, diabetes was most common, but I think the most relevant column in this table is to look at the participants who did not have type 2 diabetes. So actually, a third had ischemic or hypertensive nephropathy, but actually a larger number had CKD due to chronic glomerulonephritis. So for example, IgA, which is the most common primary GN in the world, was about 16%. Then you have FSGS, membranous, minimal change, and then you have other, which is catch-all for perhaps Alport disease. I don't know, but this is exciting because a lot of studies don't have very small numbers of patients with GNs. And then it included other causes of CKD, patients chronic pyelo, chronic interstitial nephritis, even obstructive neuropathy, renal artery stenosis, and about 500 patients in this group actually had a kidney biopsy, to demonstrate to confirm the cause of their kidney disease. Presumably, most of these are the folks in this GN group. And so specific, so one of the the patients cases that I talked about earlier is a gentleman with IgA nephropathy. So there's a subgroup analysis that's been done looking at these IgA nephropathy patients. So there were 270 individuals in DAPA-CKD who had a diagnosis of IgA nephropathy. Most of them had a kidney biopsy to verify the diagnosis. But again, these are the same outcomes. So the composite outcome, and then the renal specific composite. So this is looking at all the patients. So everyone who'd had a label of IgA nephropathy, whether or not they'd had a biopsy. And then C and D are the same outcomes in the patient, restricted to the patients who'd had a biopsy. But again, this was most of the patients. And you can see that, clearly there's this, separation. Despite the smaller numbers, actually there was a significant reduction in, renal outcomes in patients with IgA, which is very exciting because we don't have a lot to offer our patients with IgA. We have we do put some of our patients on immunosuppression, but really the data for putting these patients on immunosuppression is unclear at best. Okay, and then outcomes in patients with FSGS. So my patient that I talked about has secondary FSGS, probably from obesity, longstanding hypertension. This is data looking at patients with primary FSGS, which is immune mediated. And so this data was presented. I got this slide from Twitter, but this was data presented at the European nephrology meeting a few months ago and hasn't yet been published. But looking at the outcomes in glomerulonephritis and then FSGS. And you can see that in glomerulonephritis, there's clearly a benefit of dapagliflozin over placebo, and it looks like in FSGS there's also a benefit as well. But again, the statistically limited due to the small numbers. And so again, this is exciting for the patients that we see. And then so those are we talked about the different kinds of causes of kidney disease in the patients that were included in the study. And then the other thing I wanted to look at was, so what's the distribution of, GFR, what's the kidney function, and how much albuminuria. And so the inclusion criteria included GFR from 25 to 75. You can see that the majority of patients are in this, 30 to 60 range. And then the albuminuria category, so the patients had to have at least 200 milligrams per gram. And so there's, this, but majority are in this, the orange and blue bars. The majority of patients have somewhere between 300 milligrams per gram to 3,000 milligrams per gram. Okay, and then of course the question is what to do. Patients up with GFRs as low as 25 were enrolled, were eligible for the study. What to do, but we have a lot of patients whose GFR might be lower than that. What to do with those patients? And so, but looking at first at the folks that had stage 4 CKD, meaning the GFR was less than 30 mils per minute per 1.73 meters squared, there were 624 individuals that met this criteria. And then again, subgroup analysis, looking at outcomes in those folks. And so all the 95% confidence intervals cross 1. So it's not statistically significant, but looking at the curves, it looks like these patients benefited well. And then the authors, did some analyses looking at interactions, meaning, do we see a difference in the way, patients with stage 2 and 3 CKD respond to dapagliflozin versus, how patients with CKD4 respond to dapagliflozin, and it looked like there was no difference. So it looked like there's no difference in treatment effects between lower GFR with higher GFR, and there was also importantly no difference in adverse events between higher GFR versus lower GFR. Of course, using knowing that that we often see a small drop in GFR when we start SGLT2 inhibitors. Of course, we were more concerned about the folks that have a lower GFR to begin with, and so, but this, I think these curves are, are reassuring that even though these folks are starting with a lower GFR, the drop in GFR, they eventually, recover, and then the GFR ends up being higher in the dapagliflozin group than placebo. And again, no difference in the change in the GFR slope between patients with stage 2-3 CKD versus stage 4 CKD. Okay, so back to the cases. So, 57-year-old man with secondary FSGS, creatinine is 1.4 to 1.6, which I think means his GFR is in the 50s, and then urine albumin to creatinine ratio 538 milligrams per gram. So I think that, for this gentleman, an SGLT2 inhibitor is kind of a no-brainer. I think his GFR, I think he would fall into this category by GFR, and by urine albumin to creatinine ratio, he would be in this orange bar. So clearly, there, he would be well represented in terms of GFR and albuminuria. And then my second gentleman with the IgA nephropathy, his creatinine is 1.75, so he's in this category. And then his his UACR, his albumin to creatinine ratio was actually a little bit lower than the 200 milligrams per gram that was required for entry into the study. But again, he's 54, so maybe he doesn't, meet he wouldn't have met study criteria. However, he's 54, his GFR is already, I think, in the low 40s. And so, his UACR seems close enough, to me to be pretty confident that he's going to benefit. And then my young woman with Alport syndrome. So her kidney function is good, but she has a lot of proteinuria. So she would be here in this group by GFR, and then probably in this blue bar by albuminuria. So again, there were fewer folks with her that met her criteria. However, she's very young and she has a lot of proteinuria. So I really want to be aggressive because I have met a few patients recently that were told, when they were young, oh, everything's going to be fine, but then, in their 50s, 60s, they're facing, dialysis and transplant. And I don't know if there were any Alport patients included in DAPA-CKD. I know Alport is pretty rare, but I think, given that, the evidence that dapagliflozin has had a benefit in, lots of different etiologies of chronic kidney disease, I think, it's worth any, potential risks. And then, so what does that leave? So again, I talked about, not a lot of people in this category, and only patients with GFR of 25. Patients had to have a GFR of 25 to be eligible for the study, but there's not a lot of patients in this group. And then what wasn't included in DAPA-CKD study are patients who don't have any proteinuria. And so what's next is the EMPA-Kidney study, which, according to the website, 6,600 adults have been randomized as of April. And so the inclusion criteria include CKD, the GFR 20 to 45 mils per minute per 1.73 meters squared, or if the GFR is higher, between 45 and 90 mils per minute per 1.73 meters squared, they need to have some albuminuria, so they need to be at risk of progressing. But in this group, this lower GFR group, so there's no requirement for proteinuria, so should include patients who don't have protein in the urine. And so it includes type 2 diabetics and those without diabetes. We'll get more data on our patients that will help our patients who don't have diabetes. And the primary outcomes, again, sustained a decline in eGFR, end-stage kidney disease, death from renal or cardiovascular causes. So I'm not sure when that data will be published, but hopefully sometime in the next year. Okay, so the next case is a 60-year-old man with autosomal dominant polycystic kidney disease, polycystic liver disease. And so his medications, because of his polycystic liver disease, he's had recurrent ascites, so he's on orthalidone, torsemide, and eplerenone to manage his ascites. So literally, I saw him recently, and this is, he had this question for me. So he said, Doc, I don't have type 2 diabetes, but would I benefit from Kerendia? And so prior to starting to prepare for this talk, I wouldn't have known what Kerendia was, and I would have, given my patient, a blank look, and then had to ask him, and then Google, to find out that, actually Kerendia is the brand name for this new medication called finerenone. So I was aware of finerenone. I mean, there have been, I'll show you the data that we've discussed, in our division's journal club, but I'm, not in the habit of, learning, brand names for new medications. So, but my patient had, heard about the medication from one of his, I think Facebook or some other social media support group. So finerenone is a nonsteroidal mineralocorticoid receptor antagonist. It was approved by the FDA in July, and their indication is to reduce risk of sustained eGFR decline, end-stage kidney disease, cardiovascular death, non-fatal myocardial infarction, and hospitalization for heart failure in adult patients with chronic kidney disease associated with type 2 diabetes. Okay, and so this FDA approval is based on this study, the FIDELIO-DKD. And this was published October 2020. And 5,700 adults with type 2 diabetes and CKD were enrolled. Well, how was CKD defined? So patients had to have, some albuminuria with just this GFR with diabetic retinopathy, or if they didn't have diabetic retinopathy, then they had to have, more albuminuria. All of them were, on ACE inhibitors, angiotensin receptor blockers, and then, by this time, SGLT2 inhibitor use is increasing, and so 4.6% of patients were on an SGLT2 inhibitor, which I'm sure, if the trial was done again, it probably, this probably would be, a much higher number. Patients were also required to have a serum potassium of 4.8 or less to qualify. And so the primary composite outcome was kidney failure, a sustained decrease of at least 40% in eGFR or death from renal causes. And so, again, looking, having looked at the, the Kaplan-Meier curves for, or the similar graphs for DAPA-CKD, it's not, not nearly as exciting, but there was a statistically significant reduction in risk of this kidney outcome. And again, separating the outcomes to a sustained decrease of 40% in eGFR from baseline, there was almost 20% risk. And then, but having looked at kidney failure alone, it was not statistically significant. So mainly the outcome is driven by a reduction in a significant decrease in the eGFR. And then there was another secondary outcome looking at kidney failure, a sustained decrease of at least 57% in eGFR or death from renal causes. And again, there was a almost 25% reduction in risk. And they also looked at, albuminuria. So it looked like after, 4 weeks after starting at finerenone, there was a, 30% reduction in urine albumin to creatinine ratio, which sort of remained throughout the study period. And then, of course, looking at cardiovascular outcomes, there was a key secondary composite cardiovascular outcome, which included death from cardiovascular causes, non-fatal myocardial infarction, non-fatal stroke, or hospitalization for heart failure. And this was statistically significant as well. And so, of course, what about adverse effects? The finerenone group, not surprisingly, had a higher mean serum potassium than placebo. So the difference was greatest at month 4. It was 0.23 milliequivalents per liter higher in the finerenone group than the placebo group, but then it sort of remained stable through. So hyperkalemia was reported in 18% of the finerenone group compared to 9% of the placebo group. And hyperkalemia led to discontinuation of finerenone in 2.3%. But other, adverse events, including acute kidney injury and other, quote unquote, renal related adverse events were similar between the groups. And so just, I guess, what's important or what's significant about this drug when we already have, other mineralocorticoid receptor antagonists? Well, this drug, you can see here that, the finerenone is not steroidal. The structure is different. Finerenone has a higher selectivity for the mineralocorticoid receptor than spironolactone and eplerenone do. And so because it's non-steroidal, should not cause gynecomastia or other hormonal effects. There was less blood pressure lowering seen with finerenone than spironolactone and eplerenone, only about 3 millimeters of mercury in the first month, and then at month 12, 2 millimeters of mercury, and then perhaps less hyperkalemia. So clearly in this study, there was significant hyperkalemia. Some of the earlier studies suggested maybe less hyperkalemia. I think the mechanism of that is, the reasons for that is unknown. I think it's been postulated that, some have postulated that there are mineralocorticoid receptors in the kidney, but also in the heart, and perhaps finerenone does a little bit less, acts a little bit less on the mineralocorticoid receptors in the kidney and more in the heart, perhaps. That's still to be determined. Okay, so if I kind of wish I were giving this talk in person, but this is a case of a 34-year-old woman with advanced CKD secondary to diabetes, has multiple failed dialysis access due to clotting disorder. So nephrologist has referred for dialysis access in preparation for dialysis, but has had multiple failed accesses. The patient's admitted to the hospital with a thrombosed AV fistula. And cardiothoracic surgery is consulted for a dialysis catheter placement for initiation of dialysis. And she's not on the transplant list because her GFR is above 20 milliliters per minute per 1.73 meters squared. The patient is Black. And so anyone else with the same creatinine would have a GFR of 20 milliliters per minute or less and would be on the transplant list. And so cardiothoracic surgery places a tunnel catheter, which is complicated by SVC syndrome. And basically the patient is out of access options, and then finally listed for kidney transplant. So the reason I wish I was giving this this talk in person is like maybe see some eyebrows going up, because it doesn't quite make sense. And the reason is because this is a fictional patient at Grey Sloan Memorial Hospital. So anyone who's familiar with the show, Grey's Anatomy, knows that Grey Sloan Memorial Hospital is the name of the hospital that the show takes place in. And so this episode 2 of season 18 just aired last week. And so there was I think because of all of the interest in racial disparities, which I'm going to talk about, they incorporated this issue into their episode and consulted one of the nephrologists that's involved in the new GFR equations that I'll talk about. But it's actually well done. So some of it doesn't quite make sense. It's a little bit dramatized, again, because it's a TV show. But they talk about some of the the issues with with creatinine and how it may contribute to racial disparities. And so it really was well done. Okay, so this is my segue into racial disparities in kidney disease. And so according to the NKF, a National Kidney Foundation, 37 million adults have kidney disease, and there's a higher prevalence of kidney disease in minority populations. So for example, this graph shows the dialysis or the prevalence of end-stage kidney disease from 2000 to 2018 by race. So at the end of 2018, among patients who identified as white, there were 1,700 cases per million of end-stage kidney disease. A little bit higher in Asians and higher still in American Indian and Alaska Natives, and then in Black population, over 5,800 cases per million. And so if you look at these patients with end-stage kidney disease, you see that a smaller proportion of Black patients are on home dialysis or are living with a transplant. So this is the distribution of the modality among dialysis patients or among end-stage kidney disease patients by race at the end of 2018. And so just to look at these bars, so 33% of white patients with end-stage kidney disease are living, with a transplant, compared to 20.9% of of Black patients. And then these two bars represent home dialysis modalities. So you can see that a lower percentage of Black patients are on a home dialysis modality than white. And so, why is this? Well, because lower rates of transplant in Black patients. And sorry, I seem to have lost my legend here, but the navy blue lines represent the total number of transplants per 100 patient years. So in white patients, this is 3.9, and Black patients, it's 2.8. And I think what was striking to me about this graph is that things are there's significant disparity now, but if you look back 10 years, almost 20 years, things were much worse. And then this looks like it's mostly driven by, so the gray line is living donor transplants, and the red line is deceased donors. So that you can see that there are many more living transplants in white patients than there are in Black patients. So lower rates of transplants means that, more patients are waiting, for a transplant. So this shows, median wait time for a kidney transplant among dialysis patients. So for white patients, it's, 41 months, whereas, for all the other groups, anywhere, about 59 to 60 months. And so the way we've been estimating a kidney function for some time uses a multiplier for female male and a multiplier for Black. And so so this has gotten a lot of attention. Not to say that this there are a number of different factors that lead to racial disparities in chronic kidney disease, and I don't claim to be an expert. And of course, these disparities existed, before these equations were generated. But the question is, are these equations potentially, perpetuating racial disparities? And so, for example, this was a paper from 2019, asking the question, do the current eGFR equations disadvantage Black patients? And so, race is a complicated, it's a social construct. So if, for the same measured creatinine, someone who identifies Black has a higher, GFR compared to a non-Black person. And so what are the potential effects? How does this potentially affect their care? And so, if a Black patient has a higher GFR, they might be a higher risk of receiving inappropriate antibiotic doses or other medications. And again, higher GFR potentially means a longer wait time, right? Because there's a cutoff. So the current cutoff is 20 mils per minute per 1.73 meters squares, and to be listed for a transplant. And does it delay referral to a nephrologist for management of chronic kidney disease, right? Because it's not recognized until later. And how does it affect timing of dialysis? So higher GFR, may delay, probably means later initiation of dialysis. This one, I'm not sure if it's a benefit or a harm. I think some patients are maybe starting dialysis earlier than necessary, so this may actually not be a negative. But regardless, the use of kidney function estimating equations that include race, can cause problems with transparency, may unduly restrict access to care in some cases. And so the marginal improvement in accuracy may not justify the use of this demographic variable. And so how do we begin to address some of these racial disparities? So over I think middle of 2020, some institutions began removing race from GFR calculation. And typically how this was done was just to pretend, just to disregard the African-American GFR and use a non-African-American GFR for everybody. And then meanwhile, the National Kidney Foundation and the American Society of Nephrology formed a joint task force in August 2020 to focus on this issue. And then just a few weeks ago, on September 23rd, so this task force, the National Kidney Foundation, American Society of Nephrology, released the task force released their recommendations. And on the same day, the New England Journal of Medicine published these two studies, which talk about estimating GFR without race. And so what were the task force's recommendations? So there were two main recommendations. One is to immediately implement this CKD epicreatinine equation refit, so a new equation without the race variable in all laboratories in the US. And then recommending national efforts to facilitate increased routine and timely use of cystatin C, especially to confirm eGFR in clinical decision making. So what are these recommendations based on? So I'll start with the first New England Journal study, new creatinine and cystatin C based equations to estimate GFR without race. And so the authors developed a new creatinine based equation using data available from 10 studies with 8,000 individuals. So these are all individuals that had their GFR actually measured, whether it's iothalamate or some other method. 31% of these patients identified as Black. They also developed new cystatin C and creatinine cystatin C equations, from again an additional 13 studies. Nearly 40% of the participants were Black. And then these equations were applied to these validation data sets of 12 studies with 4,000 individuals. Only 14.3% of the individuals in this validation set were Black, which I think is a limitation of this approach. However, so the result. So this is I try to sort of walk through these graphs, but so you have estimated GFR on this axis, measured GFR. And so, of course, the closer we want, so black is the line of identity, means, and if you're on this line, that means estimated GFR and measured GFR match exactly. But you can see that there's quite a scatter. It looks like kind of a scatter plot. A lot of points are not that close to the line. However, so yellow is non-Black participants, green is Black participants. But I think the key things to take away from these graphs is to they're looking at the bias. So bias is measured GFR minus estimated GFR. So how far apart are the measured GFR and estimated GFR? You can see that in non-Black, it's pretty good. It's less than 1 milli per minute per 1.73 meters squared. In Black participants, it's minus 3.7, meaning that the estimated GFR is actually, is higher than the measured GFR, meaning that that GFR is being, is the estimated GFR overestimates the true GFR. Another measure they looked at was this P30. So it's what percentage of the estimated GFRs are within 30% of the measured GFRs. And it's, 89% for non-Blacks, 85% for Blacks. And then another measure they looked at, correct classification. So if what CKD class would the estimated GFR assign a patient to? Does it match with what the measured, GFR stage? So for example, if the estimated GFR puts someone in stage 3A, is the measured GFR also putting them in that same category? So you can see clearly there's a bias for the Black participants, more so than the non-Black. And with yours using the current way, we estimate GFR using creatinine. So this middle is looking at what happens if you just ignore the African American GFR in the current equations, which is what a lot of institutions did. They just discarded the African American. Everyone gets assigned the non-African American GFR. Again, the non-Black participants, their estimation GFR is not changing, but what happens? It actually introduced a bigger bias for the Black participants. So measured GFR is over 7 milliliters per minute per 1.73, higher than estimated GFR. So we're underestimating, significantly underestimating GFR in Black participants. And then this was a new creatinine equation which does not have a race coefficient, and it's it actually is still it's about the same amount of bias for the Black participants, and but introduces this almost 4 milliliter per minute 1.73 meters square bias in non-Black participants. And again, about 86 to 87% of the estimated GFRs are within 30% of the measured, and about 2/3 of the time patients are being put in this the same stage. So it's a new equation. It doesn't have a race coefficient, but it's not great. There's still bias, and so they looked at cystatin C. So if you check cystatin C now, there already is an equation to estimate a GFR using cystatin C, which has no race coefficient and has never had a race coefficient. And actually, you can see that it's pretty good. So the bias in non-Black participants is less than 1, and then there's almost no bias in the Black participants. So based on this, so the authors created a new creatinine equation, but pointed out that cystatin actually works. Cystatin C works pretty well, or works better. Okay, and then the second study, looking at 1,200 individuals from the CRIC study, 37% of those individuals were Black. So the authors randomly selected a subset of patients in the CRIC study to undergo direct measurement of GFR using iothalamate, and then to determine whether GFR could be accurately estimated without including race. So I think the main point of this slide, so this is their attempts to create a model that incorporates creatinine, age, and sex, that excludes race or any sort of, African ancestry or any sort of race variable. And what happens is there's a significant difference between, the measured and estimated GFR, which is much bigger in Black participants than in non-Black participants. So they actually, they were by using, reported race and African, so genetic markers of African ancestry, they were actually better able to, estimate GFR. But the whole goal is to come up with something that does not include race. And so they looked at, cystatin C, actually, and again, cystatin C, age, sex, right? So this model has no reported race or African ancestry. It works pretty well. And whether or not you have, reported race or African, it doesn't, the accuracy, does not change. So again, I think the point of this chart is just to show that when, the creatinine it's what we're using, it's kind of established what we've been doing, but it's, there's significant limitations. And so, for example, when they tried to, remove, have a model that didn't include race, so only, so 86% of, or 81 to 86% of the estimated GFRs are within 30% of measured, but only, less than a third of the estimated GFRs are within, 10% of estimated. But even the best models, only about 40% of the estimated GFRs are within 10% of the measured GFRs, which to me, even as a nephrologist who always, I'm keenly aware of the E in estimated GFR. This was, data was still, these numbers were still, surprising to me. Okay, so going back to, so this data, these papers sort of form the basis of this recommendation, is to, immediately we know that creatinine is not a great measure, but we want to do something now, and so we want to start by removing the race variable, and then recognizing the shortfalls or some of the limitations of using creatinine, try to increase the use of cystatin C, and again, that's not something that's going to happen overnight, so it's more a practical step one, and then goal maybe a longer term step two. And so I think anyone who's tried to order cystatin C knows that it's not, it comes back. It doesn't come back, within an hour or two like the creatinine does. It's, it's a little bit more expensive, and whether I've tried to order it sometimes and I get, an ABN notice saying it might not be covered by insurance. And so that's, there's a lot that has to be worked out to make cystatin C more usable, but I think it's, it's the right thing. Okay, but in the meantime, so there's a new creatinine equation without race. So how do you use it? So you can do a search, and you'll end up on the National Kidney Foundation website. So this is a calculator where you can just put in the numbers, male, female, and then it pops pops the results. So I actually did this for a patient because I was curious to see what so by using the current equations, the CKD epicreatinine for non-African Americans 21, for African American 24, and so putting in her creatinine, her age, it comes out. The new equation, is 22. And then I happened to have ordered labs for a patient who I'd seen several months ago. Who I'd seen her for, she had a little bit of hematuria and some proteinuria. She's very young, she's very petite, and so I thought, her kidney, her creatinine was okay, but I worried that perhaps the creatinine might overestimate her kidney function. So I had said, let's check a cystatin C the next time you get labs, and so these popped up the other day. So I plugged in the numbers. And you can see that the CKD epi, the creatinine eGFR was 92. Actually, was lower than the cystatin C. So, but by either, this is reassuring that by either measure, her kidney function is quite good. And so I think with I think we all, so I just want to, remind everyone that, the E in eGFR is probably the most important in letter, and that we don't, because GFR sometimes, gives us a little bit more confidence, or it gives the illusion of, more accuracy than we actually do. And so, but we focus on this, the GFR, but don't forget, to check, to look for albuminuria, proteinuria, because, if we, because we don't want to miss, those folks. Why is albuminuria important? Because of, you can see that, these, all the red and orange squares, right? So because albuminuria is associated with all-cause mortality and cardiovascular mortality. So don't forget about albumin. Don't, focus only on the GFR. And so in summary, again, remember the E in eGFR. So the creatinine equations are, well, depending on your definition, they're pretty good, but they're not great. Fortunately, most of the time, we don't need an exact to know exactly what a patient's GFR is. We just need to have a ballpark. But if you have anyone who's on the borderline of between stages, or have hematuria, albuminuria, consider checking a cystatin C. And again, don't focus just on the GFR. Check for albuminuria. And then if you have anyone with chronic kidney disease with albuminuria, of course, ACE inhibitor ARB is still the first thing to do, but consider adding an SGLT2 inhibitor, especially in the patients who don't have diabetes. So I think diabetics may be seeing an endocrinologist, but I think there are many more patients with chronic kidney disease than nephrologists can manage alone. I think there are somewhere around 8,000 nephrologists in the United States, and there are tens of millions of patients with chronic kidney disease. And so we rely on, our primary care physicians. Well, we know that a lot of primary care physicians are managing chronic kidney disease. So consider adding this, this to your arsenal of patients with chronic kidney disease. And then finerenone, I personally have not prescribed it, nor I took a little poll of my colleagues. None of us have prescribed it yet. I think maybe consider if there's an indication for mineralocorticoid receptor antagonist, but not tolerating spironolactone, or a eplerenone. I'm a big fan of MRAs, and I prescribe them a lot for difficult to control blood pressure. But I have patients who have trouble getting eplerenone covered. So I don't know how much. I imagine that costs may be prohibitive for a lot of patients for this new medication.